Great.
We are live.
This is Senate Appropriation. It's January 13th. We're going through budget adjustment and requests. Today we have one Department of Health. Up for the record, you can introduce yourself, and if you have anybody else with you.
Yes, Bill Brent, Commissioner for the Department of Health, and I've got Megan Health with me.
Great.
So, as I've done this a couple of times now, I'd like to use this as an opportunity just to really introduce myself,
Yeah.
a little bit about what landed me in the seat and some of the observations I've made, priorities for this coming year, and then we'll have a brief BAA, which is relatively short. So I've been in Vermont now for 13 and a half, 14 years. I finished my residency training program over at Dartmouth, and I'm an inpatient hospital medicine doctor, so I see folks in the inpatient unit down the line. And when I started my clinical practice, there was a couple of things that were immediately apparent to me in medicine. One was that I can't solve the problems of my patients within the four walls of the hospital. The problems are too big. The challenges that our patients face really require more than just being at the bedside. And they require community partners and a whole system of care. And that led me to reach out to our community partners, the primary care physicians in our community, the DNA system, the skilled nursing centers, to try and coordinate care better. Because there was some real gaps that I was seeing leading to increased care utilization, readmissions, ED utilization, a lot of the problems that we still see now. We worked with a stakeholder group that ultimately turned into something called the Rutland Community Collaborative, which was a really great organization that continues to this day and does help improve outcomes related to those sorts. Unfortunately, despite that great work, the problems still exist, and we still see revolving door admissions. We still see that to this day. And in no small part, it's due to some of the social drivers, health issues that we see around our state, lack of access to transportation, finances, food, healthcare. And those really led to a lot of these challenges. And we started working on that both at the hospital. I started working outside of the hospital to try and help with some of these challenges. Boards and commissions, both locally and across the state. The other thing that was very clear to me when I started working was that there were decisions that were being made in the hospital that didn't really have any clinicians at the table. So I started inviting myself to a lot of committees. It wasn't that they didn't want physicians or nurses there, it's just that there wasn't people who were interested in doing that work. People didn't really raise their hands. And that found me on a leadership track at the hospital and a series of promotions over the course of 10 years into a sort of executive position role, which before leaving, I was something called the Chief Medical Information Officer, which is this interesting interface between sort of IT systems, EMRs, and physicians. Really interesting work, a lot of data work and electronic systems, and gave me a broad perspective of some of the challenges we see not only locally, but around the state. I did join the board of medical practice, served as their chair for 4 years. So I got involved a little bit into the regulatory space and licensing space, which was really interesting to me. Introduced me to the federal groups as well, the Federation of State Medical Boards, which is a great organization I worked with for a number of years. And some other boards and commissions around the region and the state, so the local designated agency I got involved there because mental health is such an important part of our physical health, and coordinating those systems was very important, as well as VIPE, which is a IT state. So anyway, that work was really interesting and exciting to me. I also was the COVID czar for the hospital and got very involved in the COVID response, which served as the infection committee chair for a number of years. And for a while, I had said to myself, if and when I decides to retire, I consider throwing my hat in the ring. And when that time came, a lot of people sort of pushed me to consider that. And 6 or 8 months later, I found myself at the Department of Health after a pretty long process.
When did that happen? Just last summer?
October 13th. Today actually marks the end of my 3rd month.
Okay. Great. Well, thanks for doing it.
Yeah.
So you're not able to practice at all.
I am
Yeah, you
actually.
are.
Yeah, I'm still. So my practice is very limited. I see inpatients 4 days a month, which is great, and it keeps me grounded in sort of patient care and no leadership or any kind of.
Yeah, you go to Rutland to do that.
Yeah. So since being at the health department, I've been really impressed with a lot of the work that happens there. There's so much, and I've learned so much. Yeah, so the mission and vision and values is something that really spoke to me even before I started seeking out this role. And one thing that was also true and still is true is there's this attack on science and public health around the nation, and that's sort of a calling to me as well to sort of seek out this role. And this sort of mission and vision spoke to me and still does about the work of public health within our state and the work that we do. Public health is a challenging thing to define for folks since it's sometimes difficult to articulate. We use this way of describing it as detect, connect, prevent, and respond. I can give a tangible example of how this works. So a few months ago, we detected the case of the process moving box in Washington County that led to a number of cases there. We responded by providing the community with resources and information to protect themselves, PPE, immunization support if they needed it. We alerted the healthcare providers in the area to help prevent the spread of that illness. So that sort of detect, connect, prevent, respond approach really worked well there. Our work goes beyond infectious diseases. We have tendrils in many parts of the state, including in our school liaisons, collaborate with partners to improve health outcomes with Vermonters that have challenges with hot and cold during the hot and cold seasons. Workshops on healthy behaviors, drink, smoking, you name it. There's so many different ways in which the health department connects with our community to try and improve the health of our state. This is our organizational structure, which I find very helpful to remind myself all the ways in which we help support Vermonters and also the ways in which they're connected. Just as to orient yourself, sort of the green little we call chiclets here are parts of the commissioner's office, and the blue ones are the different divisions that support various things around our state. So whether it's environmental health, the lab, local health, family and child health, the different divisions are in the areas that report out to our division department. Our work is pretty varied. We have some very concrete clinical works, such as the Office of the Medical Examiner. We do some home nursing visits for new families, laboratory testing. And then we have more community-based work like preventing chronic disease, health promotion, environmental health, water and air quality, as well as food safety. We have experts in all these fields, which is great because I am not an expert in all these fields, but we have wonderful folks who have a lot of knowledge that we can rely on. And if there's ever a question about these fields, I've got someone I can bring in that can give you all the information you can sort of want. So one thing that was very clear as a job for me was to preserve the trust in public health. We left the pandemic with a high degree of trust in the health department, and that is not the case around the entire country. There's some health departments that really left the pandemic with a very tarnished reputation. And I credit that to the work of Dr. Levine and the health department and serving as that resource. It is my responsibility and our responsibility to make sure that we remain that trusted source for Vermonters, the stable rock that people can rely on. The good news is we have a lot of resources in local communities that people do know, and when people make personal connections, that's where trust comes from. So in our district offices, in our schools, we have workers that connect with the local individuals there within our hospitals and our health systems as well. And they are really huge resources that we have to pull on to ensure that we continue to connect with the public. So there's a few specific things that have come up in the last 3 months that I know are focuses of mine, will be focuses in the coming months. The first one is on immunizations. And speaking of trust, there's been a lot of false claims and falsehoods in recent months that have been fueled by uncertainty and some of the changes in the CDC. We have been working very hard to ensure that Vermonters continue to have access to vaccines. They continue to have access to evidence-based information on what's recommended. We had a pretty big announcement last week from HHS around changes to the vaccine schedule, which has caused so much confusion.
But the announcement is you're not changing.
Our announcement is we're not changing anything. The HHS announcement is that they're changing a whole heck of a lot.
Right.
And we are working with our legislative partners to ensure that we have some changes that are needed to make sure that we can continue to rely on trusted sources, that we continue to have access for Vermonters, and that our insurers are going to work with us.
Have you seen any reduction in vaccines, or is it too early?
So the feedback I've received from pediatricians is a lot of confusion by folks. So a lot of people are confused about these changes, and that can lead to a lot of questions, which is good. Questions are good. People need to go to the right source for their question, which is their trusted healthcare provider, their pediatricians or their nurses or those sorts of things. So yes, it has caused a lot of confusion, and that's really been the main sort of change, if you will, right now is just confusion and uncertainty. There hasn't been any financial impacts to access the vaccines or things of that nature. It's just caused a lot of confusion.
Are people choosing not to vaccinate?
Right.
Vaccination rate going down at all?
So we do track vaccination rates, and the good news is overwhelming majority of Vermonters do vaccinate their children and vaccinate themselves. The things that can fluctuate from year to year, things like flu and COVID, and we've seen a little bit of a dip in those, which is concerning to me, especially this year where we had a particularly bad flu season. Flu has really been a challenge around the country, and we're seeing that more and more now locally. So yes, there has been a bit of a dip in that. So substance use disorder is another large focus of mine because it's a need. I mean, we've had challenges in substance use disorder in Vermont for years. Frankly, we've done a very good job in responding to this. The hub and spoke model I've seen in my clinical practice is very effective. Many folks that I see on the inpatient unit, 10 years ago, I saw a lot of patients that were actively using IV drugs and had no engagement in treatment at all. And it's rare that I see that now. I see relapses for sure. I see folks that are using IV drugs, but most people are engaged in treatment at some level. And a lot of folks are on MOUD, or on Suboxone or methadone for treatment, which is really, really encouraging. The number of cases I see of infective endocarditis, which is an infection of the heart valve you see with IV drug use, those have gone down a lot. They're not gone, they're down. But the field is changing. Not only do these substances change, and we're seeing a transition to stimulant use disorder, which is a significant concern of mine, because the treatment for that is entirely different. There is no MOUD essentially for stimulant use disorder.
What's that?
Yeah, meth, cocaine. Cocaine is
No, what's the treatment?
MOUD. So methadone and Suboxone, that doesn't exist for stimulants. What we use is other types of incentive-based programs that have been effective, but there's not as strong of those types of therapies. So it's different. And meth specifically is a big concern of mine. It's a really, really, really bad drug. The colleagues I have around the state or around the country who care for folks where there's a lot of meth, it's harrowing the stories you hear. People are very aggressive and violent. It's a really, really challenging thing.
Just the acronym MOUD.
Sorry.
Okay.
Sorry. Medication. Medication.
Opioid use.
Opioid use disorder. Yes. Yeah. That's
As compared to used to be MAT, right?
Yeah.
right.
Medication assisted treatment.
Right.
And that's the methadone.
Methadone and Suboxone. Yes, that's the primary medication.
Thank you.
Anyway, so yes, that is a concern. So the other piece though with substance use disorder is residential treatment is a really, really important part of this puzzle. We have some lack of capacity in some of our residential treatment areas. We recently were able to work with Valley Vista to open a number we call 3.1 beds, which are lower acuity treatment centers for longer durations of time to really meet a critical need. But there's more capacity needed in our substance use treatment spectrum. I think we'll see now that we have some more of the treatment, lower acuity treatment beds open, we're going to see gaps in the recovery residences. So these are much longer term residences for folks who are getting on their feet and getting jobs and those sort of things. We had those, B4 is a big organization in Vermont that has a number of beds, as well as Jen's Promise Ben's House. We're going to need more. So that's another area that we've been focusing a lot on as recovery residences. And the last one is around access to care. I've seen a number of places where I'm concerned about access. This is obviously something near and dear to my heart. I've been in healthcare my entire career. And I've been concerned about some of the things that are happening in obstetric care, the transportation challenges that we're seeing currently and that are exacerbated in healthcare. If we want to be truthful to this healthcare transformation and regionalization effort, we need to have the transportation systems in place. We don't have that. And that's something clearly that's within the health department, and I have focused on, and then reach out to healthcare to ensure that we have access.
Do you have any kind of liaison with agency of transportation on the transportation issues?
Most of the transportation that we work with is emergency medical services. So the EMT system is the primary sort of space, but absolutely work with all state agencies around these sort of concerns. But that's the main one. And within the EMT system, the system's designed to respond to emergencies. It does that.
Because in transportation, we're dealing with more like getting people their dialysis.
Right, and that is an issue. The ability for someone to access their medical services is challenged, and I've seen that in my own community, and I know that I've seen that around the state where people just struggle with transportation. I've heard transportation challenges come up in almost every single discussion I've had on varied topics. It's not just healthcare or health. There's just so many transportation challenges.
Hear that, Richie?
That, we did put money in to help with recruiting volunteers. And we haven't thought of where that effort has moved, but the public transit agencies have had less volunteers than they went down during COVID, it hasn't come back. And I would suggest to you that as AHS talks about consolidation of healthcare services around the state, it becomes even more important to be able to push that. And there will certainly be an effort between health and welfare and our transportation committee look and push that. And I'm hopeful that in the governor's budget with the agency that they are backing up those efforts.
Yeah, I mean, certainly, again, in the healthcare sphere, the system's designed to do which is respond to emergencies, not to transport people between systems, which we need to do. We need to do that. It needs to be paid for. It's not, and it can't be floated by the state. It needs to be something that insurance companies are reimbursing when transporting on the EMS systems are doing this. Because we're going to have centers of excellence and regionalization. We need that.
We've long transported people to the public transport agencies to dialysis and
yes.
And it is concerning that we have less volunteers now than pre-COVID.
Agreed.
And I'm sure that the chair of health and welfare will back up all of this.
And well, and maybe we can do something together.
Yes.
Yeah.
We will.
Yeah.
So those are some of my sort of immediate priorities for the year, and I've got Megan here to talk a little bit about our BAA. If there's any other questions, I'm happy to answer.
Thank you, Commissioner. Welcome aboard.
Thank you. Appreciate that.
For the record, Megan Hope, Financial Director of Vermont Health. We have a brief budget adjustment this year to present to you all. The first item, as you can see, is sort of housekeeping, if you will, similar items in the past years. That's a transfer from the Agency of Human Services Central Office to the Health Department for our Agency of Digital Service expenses. So annual costs that are billed originally to the agency, and then once the agency kind of looks at all those allocations and figure out each department's needs, they then allocate the money out to the department. So that is that first
This is
one.
like, do you know where it is in that our worksheet?
Oh, I'm sorry. Yes, it is.
Three.
Yeah, B311, because it's in our ad appropriation. I'm sorry about that. Page I believe it was on page 11 of the age.
Page 3 that we.
Okay. Oh, yes,
We only have.
you have a big copy.
But yeah, B311.
Yeah, B311. Sorry about that. So that's the first item. Our next item is in section P312 in our public health appropriation. And we are asking for a swap of funding from investment global commitment dollars to general fund to help replace the funding that the health department issues to Planned Parenthood of Northern New England through a subrecipient grant. This funding use was global commitment investment, but because of the federal HR1 bill, there's a 1-year moratorium or pause on Medicaid payments to Planned Parenthood. So in order for us to continue providing these services and this funding to Planned Parenthood, we're asking for general fund to back up the global commitment that we can no longer request from the federal government. And
that's it.
those are the two items.
There was even on our worksheet that we don't have the detailed of all the reversions. But we got a reversion report that showed Department of Health reverting funds from that health disparities and health equity.
Oh, yes, that is it's a one-time request within the, it's a one-time appropriation to basically when the Office of Health Equity, and I apologize, sometimes I get the Office of Health Equity and the Health Equity Advisory Commission confused. We went that.
Those both within the, wasn't the
Yes,
question about where they were gonna live?
Yes, they were originally appropriated within the Agency of Administration, and then they've since moved to the Department of Health. So that one-time funding request is basically to revert from AOA back into the general fund to then give the money back.
So we appropriated AOA, but since it's within the department, it needs to be converted and reappropriated.
Yeah, and that is a one-time, that's in the one-time section, for $163,000 of general fund.
That makes sense. Yeah. No,
For the record, Noel and I will join fiscal. If I can point something out really quick
sure.
about the grants, the 300. Even though it looks like it's up of general fund of 300, it's actually only an increase of like 170 something thousand because the GC's match. So that's the federal and state. So it's really only an increase of like 170,000 general fund.
Okay.
But you would know that.
Right.
So I just want to flag that
Yeah.
it's not really 300, it's less.
Yeah, we forget that, or at least I just. Okay. Thank you. Any other questions? Department of Health Finance or the Department of Health or the Commissioners? They're good. They're good. All right. Well, I think we're.
Thank you very much.
Thank you. Your work.
No, you throwing it everywhere. Thank you.
Do we not POCs online or
It should be.
in person?
Maybe they're.
Meeting. We'll move directly to DOC if they're here. Yeah. They're not there.
It almost like it's.
They're gonna give all of them there, but we're specifically doing it. Nor see if there's any department for officials though.
Maybe it's time to do like, get together, just.
That's what I want.
Bring my.
Yeah, you know.
I don't know when.
I'll be back.
But we'll go offline while we try to find.